You can define sex for yourself, but
Mhm.
but sexual pleasure is yours to claim, and it's yours to design, and it's yours to claim, and you can figure out what that looks like for you. But don't be afraid of it, and don't think that it's just something for people who are super sexually active. It's not.
I'm Rachel, and you're listening to the Owning Your Sexual Self podcast. Hi, everyone. Thank you so much for continuing to listen to this episode of Owning Your Sexual Self. And we have a guest on today. Dr. Maria is with us to talk about her upcoming book, The Bedroom Gap, which talks about sex in midlife and to talk about what happens with sex during perimenopause or menopause and so much more. So a little bit about Dr. Maria is that she is an author, she's a public speaker, a women's rights advocate, a practicing gynecologist, and she is an internationally respected expert in menopause and female sexual function. Really excited. She actually has a tech talk on what happens to sex in midlife and has nearly millions of views. And then again, her forthcoming book, The Bedroom Gap, will be released in February of 2026. Actually, February 10th. Hey, that's my dad's birthday. Great day. She is the founder of Women's Healthcare of Princeton. It's a progressive gynecology practice serving over 30,000 women in the US. And to meet the needs of international and remote US patients, in 2024, she launched The Thinking Woman, which is a virtual consultation practice. She completed a BA in English with honors and distinction from Duke University, attended medical school at Jefferson Medical College, and completed her residency at Johns Hopkins Hospital in the Greater Baltimore Medical Center. She's a board certified OBGYN, is a certified menopause practitioner, and experienced sexual counselor, and has been named fellow to national societies for her contributions to gynecology. And she's one of the first US clinicians to recognize the need for a non-estrogen option to treat vaginal atrophy. In 2015, she pioneered the use of CO2 laser in the US. She has taught clinicians this technology on 5 continents. Passionate advocate to reproductive freedom and contraceptive access, she fought for over 7 years alongside Senator Shirley Turner to achieve passage for New Jersey Bill S-275, and it's a part of Historic Freedom for Reproductive Choice Act, which became active in law in 2023. She's appalled by the global pervasiveness of the gendered healthcare gap. She is working towards the construction of a women's healthcare clinic in rural Kenya. She is currently at work on a documentary about sex, menopause, and gender equality called Hot. And she is married with 4 children. Wow, a woman that truly does it all. She loves to sing and dance despite ineptitude at both. That made me giggle and loves being outside. So I'm really excited to have Dr. Maria uh, Sophocles. She's not on yet, so I'm so sorry if I butchered her name. We'll get their correct name once she gets on here. And again, we're talking today about the bedroom gap and what happens to sex in midlife, menopause, and beyond. So, without further ado, let's have Dr. Maria join us. All right, Dr. Maria, thank you so much for coming on to the show today. I'm so happy to have you here.
So happy to be here, Rachel.
Yeah, so you, as I just recorded the bio, I was saying you are a woman that has led a life in serving so many others in so many different platforms. I'm curious for you, how did this all get started? How did you land yourself down this path?
I was a board certified OBGYN, happily delivering babies and doing surgery. And my patients started getting older and they started asking me questions about menopause. And so I kind of realized how inadequately trained I was in menopause. And that was
Mhm.
maybe 20 something years ago. So had to go get trained in that and became then there just were no menopause specialists. So that became a very unique thing and built a practice that was really one of the first menopause focused practices in the country. And that just exploded. And so I got to very quickly have a lot of experience with menopausal women. And it was almost like being thrown into a study, right, of thousands of women. And I kept hearing the same kind of shameful acknowledgement over and over, which is, I don't really want to have sex anymore. And I feel bad because men have needs and my partner wants this, but I don't really want it. And when I do have it, it often hurts. And can you just wave a wand and give me sexual desire so I can just make sure he's happy? And there are so many things wrong with that sentence or those sentences. Like you and I could unpack that for an hour, right?
Hmm.
But one of them is that there's this shame around not staying sexually vibrant for our entire lives, that women feel that sex is really something for men, not for them, but that they have to stay sexually desirable and that they should desire sex and that they should want to keep a man happy. And all those things are just rooted in all kinds of messaging that to me was so wrong. So even though I'm trained as a doctor, it became very clear that these were societal forces at work. This was not just about medicine and even not even just about menopause. So when we become menopausal and the ovaries make less estrogen and less testosterone, things happen in our bodies and things happen in our brains. And that we can unpack that if you want.
Hmm.
But I also felt that there was this big messaging that women were feeling who they were supposed to be in a bedroom was one thing, and who they really were was another,
Hmm.
and who their partner thought they were supposed to be. So I coined this term, the bedroom gap, to really describe this very broad, multifaceted persona that women feel they're supposed to be throughout their lives in terms of intimacy and sexuality and sexually, and how that maybe differed as they aged and as they got to be midlife. The shame and guilt they felt for not having the same maybe level of desire or the same performance ability or the same orgasm capability that they might have had in their youth, or even a bigger shame, which was like they never had it. They never had desire. They actually always were faking orgasms, or they
Hmm.
never had an orgasm because society told them you're supposed to have an orgasm from penis and vagina sex. And for a lot of women, that's just never the case, but they just
Hmm.
didn't know. And then as I researched the book, because I ended up writing a book called The Bedroom Gap, I realized, gosh, it actually starts so young. It
Hmm.
starts with sex ed in high school or middle school when we're taught that sex equals penis and vagina. We're not taught that sex can be this whole other thing, and that women can design sex for themselves and that pleasure could be something for women. So it
Hmm.
just became a rather large topic that I felt very inadequately trained to talk about. So that's why I went and got extra training in sexual counseling. And then I started helping women one at a time, and then realized I need this message to be more broadly heard. So that's why the TED Talk developed. Is I went to TED and said, "Hey, someone's got to say this." And they said, "Yes, you're right. That's a universal issue. That
Yeah.
happens, you know." Well, they said, "Is it universal? We're not interested. If you're just a doctor talking about medicine, we're not interested." But they said, if you have something that's a universal message for women in Ghana and Argentina and Singapore and women who are rich or poor, Christian or Jewish or Muslim, then we're interested. And I said, "Yes, yes. This happens
Hmm.
to all women." So
Hmm.
that's why the Bedroom Gap sort of started as a TED Talk. And then I fleshed the book out, and that'll be published in February, but it's on Amazon now. You can pre-order it on Amazon now, The Bedroom Gap. So it's really the difference in expectations and abilities between men and women in the bedroom. Now,
Hmm.
it could even be between women and women or even men and men, but the
Hmm.
most common coupling on our planet is sexually is between men and women. And this is where I noticed this huge disconnect in what the partners were understanding about each other and what they were expecting.
Hmm. Yeah.
Long-winded answer, sorry.
No, that's wonderful. And yeah, just to add to that, also the gender differences within, right, the healthcare gap and what is
Yeah,
accessible and available to women versus men. And yeah, I think that women are, especially women that are perimenopause, menopausal, are so underserved. Even just to hear like you have to go through extra training for menopause specifically is shocking to me because
it's such a big
it is part
gap.
of the
Yeah,
human process, right? Like every woman is going to experience this in later in
right.
life. So it's like yeah, even
Why is it taboo? Why is it
I
something we don't talk
same,
about?
yes,
Even
yes.
OBGYNs don't get trained in it. Can you imagine if your dentist didn't get trained in cavities?
I know.
Or if a male urologist didn't get trained in erectile dysfunction, can you imagine? He'd be out of
Mm-hmm.
business, right?
Mm-hmm.
Now,
Yeah.
can you imagine if we said to men, you only get to have Viagra if you have really bad erectile problems that really affect you for like 6 months? I mean, that we don't do that.
Yeah.
We give
Yeah.
any man who wants Viagra, Viagra. You
Mm.
don't have to even have erectile dysfunction. You just may want to have more erections. But for
You want
women,
to have a
when
fun
we
weekend.
try, yeah, but for women, when we researched flibanserin, the first medication for sexual desire disorder,
Hmm.
we put the makers of that drug through hell. We said, oh, no, 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 no woman gets this unless they have desire problems that are so bad, and it was like, wait, why? Like,
Yeah.
we have to beg. Oh, and by the way, we're not going to cover it for anyone menopausal. Why? Because when you're menopausal, your sex doesn't matter? I guess
Mhm.
not. So we have a very double standard drug approval process,
Mhm.
very rife with sexism, rife with ageism.
Yeah.
So sexual desire for midlife women was an intersection of ageism and sexism. And I just felt that wasn't right. Like
Mm-hmm.
older women are allowed to want sex too, allowed to want to have pleasure. I mean, why is that so crazy,
I
you know?
know. Yeah. Yeah. I've had several clients or even people that I've had as guests on podcasts that are in their, 50s, 60s, 70s that are they're claiming that they're having the best sex of their life. And so,
That's right.
yeah, I think my frame of thinking around menopause is so many people see the pause as the bad is like, oh, your life is now on pause. Like, but I think there's
Right.
actually a lot of beauty in the pause. I think it's a good time, like when you start to notice these changes. I think for a lot of women, it's almost like a wake up call. Like, oh,
Hmm.
let me look at me. For some women, like the first time in their entire life, like let me start to prioritize me, my needs, my pleasure, my desire, my health, right? And yeah, and maybe that attributes, maybe you can speak a little bit more of like what shifts physiologically for women or changes in desire, or just overall those hormone changes that we experience.
So the hormone changes, the crazy roller coaster of hormonal changes perimenopause, right? So that's anywhere from mid 30s to 50. And that is where we see a lot of mood changes, period changes. Sometimes there's sexual effects, but not usually. The sexual effects seem to happen when the hormones sort of drop in menopause and then aren't made anymore. And without estrogen, we get real changes in the vagina, right? If you look at TED Talk Maria Sophocles, you see an animated video of what happens to the vagina when we take estrogen away. And it's the desert. And the blood vessels go away, the collagen goes away, it becomes painful, it becomes dry. And that's when women come into my office, sort of mid to late 50s, and go, it feels like the Sahara Desert. It feels like
Mhm.
shards of glass, like terrible terminology. So no wonder they don't want to have sex. Who would want to have sex if it bleeds or it feels like shards of glass? That's where we really see maybe 5 to 6 years after menopause, the physical changes. But desire can change earlier or later. Desire can change anytime. Because remember, desire is not just hormonal or even physical. Desire can be affected by our self-esteem. What do we look like? Did we gain
Mhm.
weight? Are our boobs sagging? Desire can be relational. We're dealing with financial stress, or your mother lives with us and I can't stand her, and so I resent you, or job stress, financial stress, kid stress. All those things impact our ability to be in the moment sexually.
Mhm.
And so that can happen really. at any age, but in midlife, we seem to get a lot of it because people are at the peak of their careers when there's more job stress. They often are having aging parents, which is a whole
Hmm.
stressor.
Hmm.
Older kids does not mean no kid stress. They're just different stresses,
Different problem. Yeah.
Yeah, yeah. So it's very important for women in midlife to be able to, like you said, either sort of reinvent themselves or look carefully at their sex life and say, number one, this has health benefits for me. We
Hmm.
know that it does, by the way. We
Hmm.
know that women who stay sexually active have less depression, lower blood pressure, better connectivity with their partner, that this affects longevity.
Hmm.
So, there's something called sex span. This is how long we stay
Mm.
sexually active. And your sex span does relate to your health span. So I would urge people, your listeners, to think about staying sexually active as a metric for their overall health.
Hmm. Hmm.
And I think you can, but depending on where you're starting, you have to say, what's good and not good in my relationship? If you're in a long-term committed relationship and you're not having sex, how do you restart that? How do you jumpstart that? That's the book, The Bedroom Gap talks about
Hmm.
that, how to
Hmm.
have those conversations, how to have regular check-ins, also how to set your mind up for success, because not just the body. I mean, as a gynecologist, I can tell you, take vaginal estrogen, do this laser, we can regenerate the vaginal tissue. But, if your mind is not there, forget it,
Hmm.
right? And you know that from counseling people on orgasm and arousal and desire and all that.
Yeah. I think there's also something to be mentioned, and you mentioned earlier here as we were recording, like a lot of shoulds that people place on themselves. And should,
Mm,
we know, comes from a place of shame, and it generally coming from somebody else's expectations of what you should be doing or should be wanting.
exactly.
And I think that is a really important indicator maybe for listeners, is like if you notice yourself and you're in the fields or questioning life and there is should in any part of that frame of thinking, letting
Yeah.
that be the trigger, the indicator of, as I said earlier, like taking that pause, like taking that inventory in life. Because I think it's like what is actually true for you, or what do you actually want to be true for you? Because I
And
think
and
not,
who gets to define what sex is for you?
yeah, yeah.
Right? Because I think, so you're right, should is a dangerous term. We should floss our teeth. We should not drink alcohol. We should. But I also would say, we should give ourselves grace and
Hmm.
permission to live the life we want. I mean, within reason. Of course, I don't think robbing a bank is a good idea for anybody. Um, but I think that we have to, you and I, especially like as and your listeners, and the bedroom gap does tackle this. What are the forces that make women say, I should have orgasms, I should have orgasms every time, and if I don't, I should fake it so he feels good, I
Hmm.
should have sex for him because men have needs. In the book we talk about those forces, right? Because it's history, it's culture,
Hmm.
it's porn, right? Women, even who don't watch porn, are learning about sex from porn because their partners are learning about sex from porn. And if porn has become the main teacher of sex for men, then it's also the main should reason for women. I
Hmm.
should be able to have an orgasm in 30 seconds standing up. Who says, right? But if that's in a porn video, then somebody learned
Yeah.
that that's normal. You and I can chuckle at it.
Yeah.
But, I think especially younger women in their 20s, 30s, they experience enormous pressure to perform, to orgasm, to sound a certain way, to be a certain way sexually. And I do think in midlife, women are freed from a lot of that,
Yeah.
which is great,
Yeah.
which is great.
Yeah.
Yeah.
Yes. Yeah,
Or I hope they are. I
I was
hope
gonna say,
they
yeah,
are.
I look forward to that. I often say that, like,
Yeah.
at what age do you just no longer give a fuck? Like, when does
in
that
in
happen?
the 50s, in the 50s in general. But remember, there are a lot of women in their 50s who are divorced, widowed, newly single, or always single. They're online dating. So
Hmm.
online dating has enabled us like never before to meet partners and, if we want, have sex with them
Hmm.
frequently, regularly, multiply, whatever we want.
Yeah.
And so the good news is it kind of opens us up to sexual possibilities. But the bad news is it might still perpetuate that whole, oh my gosh, I should sound this way and look this way. I should have no pubic hair. I should have perfectly matched labia that look exactly alike,
Mm-hmm.
just like I saw in a video. There's still a lot of should,
Yeah.
at any age. So I think our society is very youth and beauty focused. So I do think there's still a lot of pressure
Yeah.
in midlife to, especially if you're single or dating or whatever, to look perfect, be sexually vibrant.
Yeah,
That's
yeah,
a lot.
absolutely. And so women that are experiencing some of these, hormonal changes or body changes, there are treatments, there are tools out there that people can take. And I often hear a lot of like women that are going through this, like they're getting a lot of different answers from said doctors. Like one doctor is telling me this, one is telling me bioidenticals, the other one's telling me not bioidenticals, like
Mm.
conversations like that. And so I'd love to hear just your frame of thinking around this. Like, if somebody is going deciding hormonal versus non-hormonal, what is your opinion on this?
Yeah, so I think every woman in midlife has to make a hormonal decision. And that decision is basically, my ovaries are no longer making three things: estrogen, progesterone, testosterone.
Mhm.
Am I going to try to put back into my body any or all of those three things?
Mhm.
And I help women by saying there are two reasons to do so. One is symptom control. I'm having hot flashes. I'm having memory issues. I'm having joint pain, or I have osteopenia or osteoporosis, or
Mhm.
whatever. Whether they're findings on testing or they're symptoms, you may want to correct those. The second is really about preservation of function in our body.
Mhm.
And that's actually the bone thing. Is we know that we start losing bone mass in our 30s. So do you want to be the 70 or 80-year-old where nature has taken its course and you've lost so much bone mass that now you're at risk of hip fracture? Or do you want to say, I want to push against that because I want to be a
Mhm.
healthier, active 70 or 80-year-old and go stand up paddleboarding with my grandkids? Me, I want to be the second.
Mhm.
I'm
Mhm.
not shy about that. So I
Mhm.
know I want to use estrogen because I know it helps my bone. That's crystal clear. That's not even debatable.
Mhm.
What's also crystal clear now is that the old thinking that hormone therapy was linked to cancer increase is actually the opposite. It's actually linked to a very pronounced reduction in cancer risk, which is
Mhm.
dramatic and wonderful good news. It's also linked to a huge decrease in cardiovascular disease development. This is
Mhm.
huge news because this is the number one killer of women.
Mhm.
It's also linked to a huge decrease in osteoporosis and fractures. So there's a lot of good news. There's not really a lot of bad news at all out there anymore about hormones. So that's great.
Mhm.
But I respect anybody who says, I appreciate that. I got it. I got it from the horse's mouth. Even the FDA now agrees with all this. I still don't want to. I just don't want to. I want to age naturally, let my ovaries stop me. And that is totally okay.
Mhm.
The difference, I think you mentioned bioidentical and not bioidentical.
Mhm.
So, bioidentical is short for biologically identical. And that just means the type of estrogen that our ovaries used to make. Because we have figured out in modern medicine how to make estrogens that are not the same chemical structure as what our bodies make, but they're still estrogens.
Mhm.
The birth control pill, for example, is made of a synthetic estrogen that's not bioidentical. It doesn't mean it's good or bad, it just is not bioidentical. Premarin was an estrogen used many years ago. Some doctors still prescribe it. I haven't in like 20 years. It's not bioidentical. Again, doesn't mean it doesn't work, it just means not
Mhm.
bioidentical. Today, almost all estrogen that menopause experts like myself use is bioidentical,
Mhm.
and it is by prescription, and it is available at your local pharmacy. You do not have to have it specially mixed up. You do not have to have it in
Oh,
creams
okay.
or troches or pellets. None of that has anything to do with bioidentical. That's very confusing to a lot of people
It
who
is. It
say,
is.
I'm on bioidenticals and I go to this fancy special hormone person who
And
for
it's
$800 mixes
pricey.
it up.
Yeah,
That's right. You
exactly.
don't You do not have to spend a lot of money to get bioidentical estrogen.
Mm-hmm.
Bioidentical estrogen is estradiol, estradiol. If you
Mm-hmm.
see that on your prescription, that's bioidentical. It's available by big drug companies. And the reason you do want to use the stuff by big drug companies is they had to have it FDA approved. That means they had to go through a ton of testing. And when you go through all that testing, what's in the box is what you get,
Mm-hmm.
as opposed to, say, compounded stuff or alternative kind of things or supplements where they don't actually have to have it, they're not accountable. So that's the difference.
Mm-hmm.
Does that make sense?
That makes so much sense. Yeah, thank you so much for offering some clarity around that. I don't think we've had that on the show yet, so thank you so much for that. Um,
Sure.
and you also mentioned something earlier about laser treatments that somebody could
Mm,
go through. Could you tell us a little bit about that?
sure. That's a little near and dear to my heart because I am the one who sort of brought laser treatment to the United
Mm-hmm.
States. And that happened because I used to live in Italy where the first vaginal laser was invented. It was invented in 2008 and it got FDA approved as a medical device and brought to America in the beginning of 2015. So the first couple machines were sent to me and to a doctor at Stanford and to a doctor at Ohio. The laser works by making little tiny dots in the vagina, little baby micro pinprick injuries, but it's painless, thank gosh.
Mm-hmm.
Think of micro needling of the face or laser on the face. Although on the face, it hurts a lot more because you have all these nerve endings on your face. The vagina doesn't hurt at all. Those little injuries cause the tissue in the vagina to say, hey, Rachel had these little dots. We better heal. We
Mm-hmm.
better make two things: new collagen and new blood vessels. New collagen makes elasticity, new blood vessels make moisture.
Mm-hmm.
Elasticity and moisture are wonderful for sexual comfort and health. They allow us to get very wet when we're aroused. They allow sex to be more comfortable. So that works. It does work. We know that. The bad news about the laser is that it's not covered by insurance because remember, insurance companies are for profit. They're not nonprofit things.
Mm-hmm.
And the laser treatments are expensive because the machines are expensive. So I have not been able ever to get it covered. And there aren't that many doctors in the country that even have them because the machines are very expensive. I would be very careful about going to get laser treatment from anyone other than a doctor's office where they do a lot of it. I would not go anywhere where they just got the machine or a vaginal health spa or something where they're also doing cosmetic treatments or steaming or bleaching or all kinds of stuff they do now that
Mm-hmm.
doesn't really have any clinical benefit. I'd be very buyer beware because a laser in the right hands is very safe and very effective. In the wrong hands, it can be dangerous. So you do want to be careful.
Mm-hmm. Mm-hmm. Yeah. Yeah, so I mean, just in this conversation, we're really debunking a lot of things here, right? Like, as you're saying, menopause does not mean that this is the end of sex. Pain is
No,
not normal at this age. While it does feel like it is
it's
common, it's
common.
not, yeah,
Yeah,
it is not normal. There are options out here for you to be able to get into. We've talked a lot about, right, lubricants, vaginal moisturizers. I've had a ton of pelvic floor physical therapists on the show.
good,
And so hopefully listeners that they already know these things as options for them, I hope.
good.
And yeah, and low desire does not necessarily mean that that has to be a relationship issue. I love that you covered that in your book as well, just how couples can
Yes,
have conversations around this because it does deserve to be talked about. And again, in that way that it's not shameful or it's not blaming
that's
somebody,
right.
right? They're
That's
just
right.
they're
It's something you can
differences.
practice. Yeah, you
Mm-hmm.
can practice that conversation. And remember I bet you've had this on the show too, the difference between spontaneous desire and
Mm-hmm.
receptive
Hmm.
desire, right? So
Yeah.
people don't have to have desire to begin with to ultimately have enjoyable sex. So I
Mm-hmm.
think that's a really like a concept that evokes a lot of freedom for women. They feel this burden that it's like, if I don't have desire, I'm stuck. I'm stuck right at the beginning.
Mm-hmm.
And, you can cultivate interest, whether it's touching yourself, touching your partner, bibliotherapy, right? Watching erotic content
Mm-hmm.
on TV or reading it in a book or one of the many apps out there where stories can be read to you, like
Yeah.
Quinn, where you can pick what
Mhm.
you like and just lie in bed at night with some headphones and the desire. I tell patients it's like a savings account. You just have to put some of that
Mm-hmm.
erotic content into that savings account.
Mm-hmm.
And then it's there when you put your head on your partner's shoulder, it feels more erotic
Mm-hmm.
than just putting your head on someone's shoulder.
Yeah.
So,
Yeah, you can
you
tap into it easier for sure.
know.
So
For
I'd
sure.
love, as we're kind of getting near the end here, I'd love to give some practical tools for our listeners. And so you, I'm sure, have some recommendations for midlife sexual health care for people. So I'm curious if we could cover some things like if somebody's experiencing this, they're listening to this episode today and they're like, okay, I want to take some action around this.
Yeah.
What maybe we can cover? What are some things that they could be asking their doctor? What are some red flags maybe for them to notice in responses that they're getting from their practitioners, how to advocate for themselves. Yeah, I'd love to cover that for people.
Sure, sure. Let's hit that. Like, what do you say if you're sexually not satisfied? So first of all, you want to figure out what part is not right. If there's pain, if sex is painful, whether that's on initial penetration or deep penetration, you want to mention that to your doctor, even to your primary care, and say, hey, I know this sounds crazy. I know you're not a sexual expert, but per se, or you might be, but if you're not comfortable, do you know someone in the community who I can talk to? And if they say yes, an OBGYN, great. If they say a sex therapist, great. Don't be afraid of that. Find someone who's comfortable talking about it. Sexual pain is never okay. And there are lots of reasons for it. If it's deep penetration, it could be endometriosis or scarring. Could be an ovarian mass. If it's initial penetration, it's usually the vestibule, the opening, that's very hormonally sensitive. And even birth control pills can cause pain with initial penetration. So you want to get that checked out. And you want to make sure if your clinician says, oh, you're just uptight, drink some wine, you are being dismissed. You do not ever want to accept that as an okay answer.
Mhm.
And accept that you're being dismissed and don't realize that clinician is not going to be able to help you.
Yeah.
Um, yeah. And I think as far as sexual desire, I think you want to ask yourself, did something trigger it? Loss of job, financial issues, relationship issues. Try to correct some of those. If the desire relates to the pain or the dryness, then you want to go back to that and get that help. Vaginal estrogen is liquid gold. It is safe for
Mhm.
every single female with a vagina on the planet. There literally are no women for whom vaginal estrogen is dangerous.
Mhm.
So I dare you, please DM me at mariasophoclesmd.com if you're a woman who for whom vaginal estrogen is contraindicated, because in 30 years I've never found one. It
Mhm.
doesn't really go into the bloodstream, so it's safe. Even if you've had cancer, it's safe.
Yeah.
So there's nobody who can't benefit from it. There's nobody who has to stop it after X years. It's safe forever.
Mhm.
So I tell people it's like using sunblock. You never outgrow the health benefits of
Mhm.
sunblock, and it should help a lot of women.
Hmm.
So I think
Yeah,
that's a good one.
that is a good, I like that metaphor.
Right? Like
And
sunblock. No,
yeah,
no doctor says, "Oh, Rachel, you're too old. You're not going to get the benefits of it anymore." It's like,
yeah,
no, you're going to get the benefits forever.
yeah, yeah. And that, how about any advice that you have for partners of women that are going through perimenopause or menopause?
Yeah, find the courage to talk to them. We never get to practice talking about menopause because the women you're partnered with don't have any practice talking about it, and their moms didn't talk to them about it. But
Hmm.
find the courage to say, hey, and admit, say, hey, I am naive about this. I never went through it, and my mom and dad never talked to me about it, but I want to learn. Where can I learn? They can go to menopause.org. They can go to my website. They can go to uh, conferences. I gave a conference in Dallas called the Menopausium. Men, these two men stood there and they said, we came down from Boston to hear you speak, Dr. Sophocles, because we brought our wives because we want them to know we really care and we want to learn. Oh
That's
my
great.
God, those two men, I'm like,
Hmm.
I thought they were the bomb.
Hmm.
So for men, don't be afraid to say, I don't know. And maybe their wives have bought some books. Say, hey, what are you reading? Like, I'll read
Hmm.
it. That's
Hmm.
okay. My
Hmm.
gosh, they could read The Bedroom Gap. The Bedroom Gap's for anybody.
Yeah,
And
absolutely.
there's so much good stuff in there about how to start conversations and what to do if you're dating, what to do if you're disabled, what to do if your partner's a cancer survivor. Not everybody's the same. We all bring different issues. Cancer survivors have different concerns. People with arthritis, different concerns.
Mhm.
Gay couples, maybe different concerns. So I think everybody deserves to have a little support.
Yeah,
Yeah.
absolutely. And yeah, and I like that the word supportive, like supportive instead of being reactive. And
Yeah.
we talked a lot in this episode around the, the should or the shame that comes from this. And so I would just add on for partners to not be part of that, not be part of their shame cycle because trust me, the
No.
women are getting enough of that in different areas.
Areas and to start every conversation, like we do when we have to talk to people at our work who maybe aren't performing or whatever. If there's
Hmm.
issues in your sex life, you can say, I noticed sex is sort of not what it used to be for us, and I did love it that time we went to Aruba. Remember that? That was amazing. One
Hmm.
thing I loved was ABC. Maybe we could try that again. Or I realized things might be different. Like, what is working for you or what
Yeah.
isn't? Approach it with curiosity, not blame, I
Yeah.
think,
Yeah.
and you get a lot further. I
Yeah.
have to remember that, by the way, for my own discussions with my husband.
Oh yeah. Yeah.
It's so
We're
easy.
experts for others, sometimes not for ourselves. So
I know. It's true. It's true. Luckily, he's a wonderful communicator. And so
yeah.
he sets the tone correctly. So you kind of have to, he sets the bar so high that you have to be good when you
Yeah.
talk to him. I'm
Yeah.
so lucky.
Oh,
So
I love hearing that.
yeah. Yeah.
Well, thank you so much. Yeah, this has been just a really, really helpful conversation. I really appreciate you coming on the show and extra appreciative for all the work that you're doing. Again, just so many different areas that you're tackling, just women's health and really bringing voice to all of this for people. So thank you. And yeah, you mentioned that your book is available on pre-order on Amazon and
Mhm.
February 10th that's going to come up. Yeah, any final messages that you have for people that are listening? What would you want them to know or take from this episode?
Oh, just that, I mean, that you can define sex for yourself, but sexual pleasure is yours to claim, and it's yours to design, and it's yours to claim, and you can figure out what that looks like for you. But don't be afraid of it, and don't think that it's just something for people who are super sexually active. It's not. And if you feel like your neighbors have sex 4 days a week because someone bragged like that, that doesn't mean they have to have more sexual pleasure than you. You can
Mhm.
you can do sex on your own terms, I think, and we all do it. So,
Yeah,
design it for yourself. And
yeah,
thanks for having me, Rachel. Really great to
yeah,
talk with you.
absolutely. And definitely give Dr. Maria a follow on Instagram. It's at Maria Sophocles MD. And yeah, it sounds like you have some good content. You mentioned your website earlier in this, so we'll make sure to link all of that in the show notes for people. And yeah, I know I will be pre-ordering your book. I'm a little book nerd over here, so I like to line all of my shelves with guest books. And so I'll definitely be adding this one to my collection.
Oh, excellent. Thank you so much. I know the bedroom gap. I can't wait to hear what you think about it. I
Yes.
really do. All
Yeah.
right.
All right. Thank you so much. Thank you so much for listening to today's show. If you loved it, be sure to subscribe so that you never miss an episode. And if you really fucking loved it, make sure to tag me on social media at the Rachel Main. I'll see you next week.